I'm Joya Delgado-Harris with the last of 3 segments providing women an overview of breast cancer screening and how we can take control of our breast health. Joining me are Dr. Richard Winder, Chief Cancer Control Officer of the American Cancer Society, and Dr. Lisa Newman, Director of the Breast Oncology Program at Henry Ford Health System and longtime society volunteer leader. We're also pleased to have with us Samantha Elmore, Lauren Jarrell, and Ginger Krawick, who will be asking those questions that are most important to them. In this final segment, we'll talk about breast self-exams and clinical breast exams. Ladies, which one of you would like to start?
I'd be happy to start us off, Joya, because this is a topic that's really near and dear to me. My question is, why do organizations, including the American Cancer Society, no longer recommend breast self-exams?
Such a good point, because I have friends and family members who've told me that they felt like they were alive because they found a lump through a self-breast exam. So why the change?
So a couple great points, and these are questions that we've been asked quite a bit, of course, since the guideline, and it's interesting because this particular guideline did not address self-breast exam uniquely. In fact, the American Cancer Society has not recommended that clinicians instruct women in monthly systematic self-breast exam, and there's a subtle difference there, for quite a few years. And no major organization does recommend this instruction in periodic, regular monthly self-breast exam. And the reason for this is pretty straightforward. There were some huge clinical trials, mainly done not in the United States because it would have been hard to do that in the United States where self-breast exam was already very common. So they're done in other countries that compared a huge number of women who were instructed to do monthly self-breast exam to women who were not instructed. And there were no differences in any of the important outcomes around breast cancer. So that's what led to organizations withdrawing any recommendation for this instruction in self-breast exam. That is somewhat different than asking the question, has performing self-breast exam helped women occasionally? Have they found something that the outcome changed because they found it a little bit earlier? And we suspect there are women who, for whom that does apply. So there are really a couple of key points. The most important is that the majority of breast cancers to this day are still found by the woman herself. So if a woman feels, notices, sees something that's a little bit different than what she is used to seeing or feeling, or she needs to not hesitate. Bring that to the attention of a clinician right away. And we do hear stories of women who think they feel a change and then they wait months and months to convince themselves. And we're encouraging women, you don't have to solve that problem yourself. Most of these are not cancer, but come bring it to the attention of a clinician. Check it out together and get that question answered right away. So we've recommended what we call awareness, that women be aware of what their breasts usually feel like and usually look like. And that awareness is developed in the course of everyday life. Washing, bathing, dressing, looking in a mirror. So I had women come up to me after the guideline and said, I had inflammatory breast cancer. That doesn't present with a mass. You see a redness, a pinkness of the breast. That, again, it's not an infection. You have to get that checked out right away. So there are women who feel more comfortable doing that periodic breast self-exam. And we would not encourage a woman who feels reassured by that to stop. But it is important to realize that feeling a lump is a different stage of cancer than finding it on a mammogram before there's a lump. And that's why mammography still holds the key to a truly early detection where the outcome actually can be improved because we found it before a lump actually appeared.
You mentioned being aware of our breasts, but how are we going to have this awareness if we're not doing the breast self-exam?
I think it happens in the course of daily life, but I wonder, Dr. Newman, I'm sure that comes up with your patients a lot because I am confident that you've seen many patients who've found their own lump.
Yeah, absolutely true. And there is a subtle difference there, Samantha. Breast self-examination is tricky. Clinical breast examination by the physician is also tricky. What we want to avoid is the risk of doing too many unnecessary biopsies, basically. And Every woman does have some lumpy bumpiness to her breast that we categorize as fibrocystic changes in the breast. Sometimes it's in the form of ridging in different areas of density in the breast. Sometimes it's in the form of an encapsulated area of fluid, or what we call a simple cyst in the breast. Sometimes it's encapsulated breast tissue, something that we call a fibroadenoma of the breast. There are a lot of different abnormalities that a woman can detect on self-examination, or that a physician can detect on clinical breast examination. And it can be very, very tricky to distinguish the dangerous lumps from the benign fibrocystic lumps. We are always wary of the risk of patients being overly nervous about their monthly breast self-examinations and excessively worrying about some of the subtle changes in the breast that are just related to maybe menstrual cycle changes, and then seeing their physician. And of course, the physician is going to accept the fact that the woman knows her own breast tissue better than anybody else. And sometimes these areas of subtle fibrocystic changes will end up having the patient to undergo a biopsy. And we don't want to do too many unnecessary or too many negative biopsies. So there can be a subtle difference. We also don't want to miss a breast cancer. So if a woman does notice a change in her breast, as Dr. Winder mentioned, we do want her to go ahead and see her physician and get it worked out. Sometimes finding the breast cancer does mean that you have to do some biopsies that will turn out to be negative in order to find the cancer. It's a very difficult dilemma.
But I think your question's a great one, because every woman feels her own breasts in the course of daily life. You know, but all of us do things where we're kind of paying attention and kind of learning, and we all do things that we just do by rote, never think about it. So now and then, a woman should really pay attention to what her breasts feel like, so that when she does have some of those questions, she is a little bit more likely to find it. I think the message is an important one, though. And it was really validated by the research in the guideline, showing the importance of mammography as the early detection before lumps appear. And that's what gives that little mortality-reducing advantage. So both clinical breast exam and self-breast exam obviously depend on a cancer being prominent enough, large enough, that you can actually feel something. Good news, most of those women are still cured of their cancers once a lump occurs. But mammography gives you that little additional advantage, another 20 to 40% lower mortality risk if it's found by mammogram.
And very important to remember that the American Cancer Society guidelines recommendation that women not do monthly breast self-examination and the leading clinical breast examination by the provider, that does not mean that a problem in a woman's breast should be ignored. If something is found, it needs to be evaluated.
Since the guideline is pretty well starting with women at age 40 getting mammograms, should women under 40 be more conscientious about doing those self-exams since they're not yet getting mammograms?
I think the key is calling it breast awareness.
Okay.
Breast cancer can occur in women younger than the age of 40, and mammograms are not perfect. They are even more imperfect in the younger aged women, because the normal dense breast tissue of young women can make cancerous changes more difficult to identify. So if a woman younger than age 40, younger than age 30 notices a change on her in her breast exam, she needs to seek medical attention. Even if she has a mammogram to evaluate that problem and the mammogram is normal, if there is a definite change there, she needs to go one step further, perhaps with other imaging modalities, perhaps with a biopsy. But any change on the breast evaluation should be worked up definitively.
One of the things that was so important in this guideline and is often lost in the discussion is how much a woman's risk of breast cancer increases as she ages. So actually the risk does not peak till you're in your 70s. And when you're in your 70s, it's about 4 times the risk of when you're at 40. So it's quite substantially larger. So I think this issue of being aware of breast changes, even between times of mammogram, is frankly just as important in any age group, because the risk for breast cancer is substantially larger at that time.
if I'm having lunch or coffee with a girlfriend, can you give me just that one way to explain, like really briefly, like why is the society no longer recommending clinical breast exams?
So thanks for bringing it up, and we'll see if we can help give that easy answer. Dr. Newman and I were talking about one of the challenges is that these decisions were the result of years of research, and lots of synthesis of information. And the challenge to communicate it briefly is one we're all going to keep grappling with. So thanks for giving me another shot. So a couple of things. First of all, people have to understand what a clinical breast exam is. And that's the exam that's usually performed annually at the time of a routine physical exam, if someone's doing that, or frankly, opportunistically when a woman comes in for another reason. But you take the advantage of that opportunity to do a clinical breast exam, and that's an exam by a professional, by a health professional. And again, in a way, this was a fairly straightforward decision on the part of the guideline committee because they looked at all of the data that's accumulated over many years through all sorts of research to see if adding clinical breast exam to mammography lowered the mortality rates from breast cancer. And the answer is pretty straightforward. We really saw virtually no effect of adding clinical breast exam to mammography. So one of the points that I've made before and reiterate is just to understand what we're able to do with mammography. Mammography is able to find that breast cancer at a truly earlier point in the cancer's natural history before it's large enough that it can be felt either by a clinician or by the patient. One of the other realities of clinical breast exam is even the studies that were done, in the research studies, these clinicians were really taught to take their time, put a lot of emphasis in it, have a very systematic approach. And just realistically, I won't say fortunately or unfortunately, just realistically, most of the clinical breast exams that have occurred in the course of routine care didn't really follow that level of time investment and kind of systematic approach. Bottom line, though, was that the research did not show the mortality benefit. And one of the things that has been happening in this country is that people said, well, you can't afford a mammogram, or you're uninsured, so we'll do a clinical breast exam. That's a good replacement. One of the messages of this guideline is your job as a clinician should be to do everything you can to help that woman get a mammogram. That's really where the investment of extra effort should be.
So, Dr. Warner, I have a question. You mentioned a statistic about women age 70 and older, and the risk increases 4 times.
Compared to younger ages, exactly, through the ages.
But yet, at that guideline group, unless I misunderstand, isn't it that guideline age group? Isn't it every 2 years a mammogram is recommended?
Right, and so remember that the interval of how often you do a test, any screening test, this is true for any cancer, not just breast cancer, is really a function of your window of opportunity. How rapidly does the cancer progress? So, for example, we only do a colonoscopy once every 10 years because we have a very long window of opportunity to find that next polyp before there's something incurable. This is the same thing we've done now for breast cancer. We know that after menopause, longer window of opportunity. So it's you can be screened less often, but that does not diminish the importance of being screened. So if you're at higher risk, the importance of being screened as you get older it should receive even greater emphasis. So this guideline differs a little bit from the task force guideline, where the task force kind of gives it a maximum age and just says beyond that, it should be a shared decision of the woman. We actually are pretty specific, saying that as long as a woman is healthy and well, and our tables suggest she has 10 years of healthy life expectancy remaining, there's a very good chance she'll benefit from mammography. 1/3 of all breast cancer deaths occur in women diagnosed after age 70. 1/3. So we have a real opportunity to reduce breast cancer mortality by being just as vigilant and just as focused on screening older women as we are on screening younger women.
Thank you for that distinction. It's that window of opportunity that
Yeah.
is important to remember. So another really important topic. Thank you for your questions, and doctors, thank you for your answers. Are there any other questions that anyone has? Dr. Newman or Dr. Winder, you have any other thing to add?
Well, it's been a true pleasure and an honor to be a part of this conversation. I've always been very proud to be able to work with the American Cancer Society, and I am especially proud to have had this honor of being able to discuss the updated mammography screening guidelines. It's important as a final comment for everybody to just bear in mind that this guideline update has a fair amount of flexibility incorporated into it. You can have a provider recommend yearly mammograms for every patient starting at age 40, and you can have another provider recommending that the mammogram not start until age 45, and at age 55 the woman transition to every other year. Both providers are have the support of the American Cancer Society. So patients will need to have discussions with their physicians about what feels best for the individual patient.
Yeah, and we're going to keep working to help women, and this series is terrifically helpful in helping us get there, but we're going to help clinicians too. We're going to be working on decision aids to help clinicians have that conversation in a really informed way with women, because the real goal is to help them tap into their own values, to help them appreciate what's most important to them for their health. The second thing I really want to emphasize is, of all the headlines that came out after our guideline, and Dr. Newman and I had a chance to talk about this, I think the one that probably hurt me a bit was they said that the American Cancer Society recommends less mammography. And I can't emphasize how untrue that is. A third of women not up to date with mammography. Millions of women who've never had more than 1 or 2 mammograms. That is not how we're going to reduce the burden of breast cancer in this nation. We have to make sure every woman has the opportunity to be offered mammography consistent with our guidelines. And even if they choose a guideline that recommends a bit less frequent mammography than us, so be it. Every woman have a chance to be screened according to one of these sets of guidelines. We think our guideline provides the flexibility and the guidance that will benefit everybody. So we remain so committed to reducing breast cancer mortality, and the only way we're going to get there is if we get this, make sure everyone has a chance to be screened. And then once they're screened, to continue to work on making sure everyone gets timely treatment, overcome the access barriers that they face, because that's our ultimate goal. We remain just as committed as ever to ending the burden of suffering from cancer, for breast cancer and all other cancers here and around the world.
That's so important. Thank you. That's a great way to end the segment. There are 2 other segments available, a discussion that provides an overview of the updated breast cancer screening guideline and what it means for women of different age groups, as well as a segment focusing on insurance coverage and women at high risk. If you haven't already viewed them, I encourage you to do so. Thank you to our guests and our 2 experts, and to you for watching.